All right, we are going to continue our discussion about diabetes and talking more about making the diagnosis and complications that can develop from diabetes. So I wanted to start with a little bit of a side note, if you will, for when we talk about screening our patients. So again, screening measures are intended for the general population who are not presenting with signs or symptoms that make you think they could be diabetic, right? And I'm going to compare ADA and USPSTF here. Another side note is that we don't do general screening for type 1 diabetics because those patients generally present symptomatic, okay? Whereas type 2 can often present with very vague symptoms, maybe not things that are screaming at us like DKA, as we see in type 1s. And that's why risk benefit for screening in type 2 diabetics, we do have parameters that have been established. So with ADA, we're going to begin screening all of our patients at the age of 35. And if that's normal, we can repeat that in 3-year intervals. And as far as what measures you use to screen, these are generally going to be the lab tests that we'll talk more detail about, such as fasting blood glucose. My preferred is hemoglobin A1C, and then you can consider a glucose tolerance test as well. Again, we'll get into more of those details a little bit later. You definitely will want to screen earlier in your patients who have a BMI of 25 or higher and one or more additional risk factors for type 2 diabetes. So remember all those risk factors, family history, ethnicity, are they a smoker, do they have hypertension? The list goes on and on. So very often we are screening our patients earlier because they fit this category of being in that overweight and have an additional risk factor, okay? There are some exceptions to the rule and special considerations to keep in mind. So patients with HIV are at higher risk for developing type 2 diabetes. Because of that, and because a lot of the antiretrovirals have a side effect of inducing diabetes, we do screen them more often. So prior to starting and when switching the antiretroviral therapy, and 3 to 6 months after. And then if their initial test screens are normal, we are testing them annually. Pre-diabetics should be tested annually, and those women who have a history of gestational diabetes at least every 3 years for their entire life. I would argue that I would test them annually. We certainly know that that's another risk factor for diabetes. USPSTF is a little bit more straightforward in their screening, but they recommend that age group just 35 to 70 who are overweight or obese. I like the simplicity of this, but I like from the ADA's perspective that we would want to screen younger patients if they're overweight and have an additional risk factor. So, kind of pick and choose how you want to approach this. I just always like to compare the different standards, and you'll certainly come up with what your comfort level is in moving forward. With USPSTF, optimal intervals are not really unknown, and they're really not specified, but it is suggested every 3 years if you have a low-risk patient to screen them. They do have a caveat of screening overweight or obese adults if they're younger than 35 with additional risk factors. So you can see there's some similarity there with the ADA. So I think a good takeaway is if you have someone with no risk factors for diabetes and they're of normal weight, then 35 is the age that you're going to start. If you have someone who is overweight or obese and have an additional risk factor, go ahead and screen them as early as you want in adulthood, 18, whatever age that might be. And then it would be suggested that, on a minimum every 3 years to repeat that. Just a reminder as well that we should always be counseling and referring our patients who have these abnormal blood glucose levels for that behavioral counseling intervention, okay? So if we are concerned that they have some risk factors anyways, we really need to take that opportunity to counsel them on lifestyle modifications, diet, etc. Finally, for type 2 diabetes in children, there is an ADA recommendation, not a USPSTF recommendation. So what they recommend is if you have an overweight or obese child, plus one or more of the following risk factors, as you can see there, I don't need to repeat that, then you definitely are wanting to screen children for type 2, okay? And we know that with the increasing rate of obesity in our pediatric population that we are seeing more rates of type 2 diabetes. And we also appreciate the sooner we can detect these patients, the better off we're going to be for their long-term complications, success of treatment, and hopefully the opportunity to, again, intervene with some of those lifestyle modifications. We want to begin screening at age 10 or after onset of puberty, whichever comes first. Okay, so for those that are 10 or after onset of puberty who meet those above risk factors, and then repeat every 3 years. Okay, but if you have some significant changes in their health history, and that's true for adults or pediatric patients, you might want to rescreen them sooner. Okay, so let's say you have an adult who they had a normal initial screen and you think we'll go 3 years, but in the meantime develop hypertension, start smoking, gain 30 pounds that would put them in an overweight or obese category, then we would want to, modify how often we're screening them.
So this is a really busy slide, as you can see. But clinically, when you see patients that present, kind of broke it down into type 2 versus type 1, um, there are definitely some overlaps. I will say less so with type 1, but with type 2, asymptomatic presentations is definitely a possibility. So they don't have to be presenting with the classic polyuria, polydipsia, etc. Type 1, they're almost always going to be symptomatic to some degree. Again, we're talking about insulin deficiency versus a slow insulin resistance on the type 2 side. So specifically for type 2, they might have some generalized blah, weakness, fatigue, headache, which is, as you'll quickly learn in primary care, pretty common complaints for a host of different reasons and sometimes no reason at all. And polyuria and polydipsia are really driven in both conditions by that high glucose load, and it's your body's way of really trying to rid itself with an osmotic diuresis, and a little bit of a slight dehydration when your blood sugars get high can cause you to be pretty thirsty. Blurred vision, that has to do again with the osmolality and how that affects the kind of lens and the vitreous in the eye and kind of that thickness there. So certainly blurred vision with both. Skin changes in type 2 specifically, you can see a lot of fungal infections, so intertrigo or fungal under the breast and body folds, acanthosis nigricans, which is the AN, and I'll show you some examples of that, and xanthomas can often present. Also in both conditions, you could have just non-healing wounds, an abrasion that's pretty, mild, but it's been there for weeks and weeks and it's just not closing up. That could be a sign. As I mentioned, clinically, you might see type 2 more commonly to be obese or overweight. Neuropathy symptoms, they might actually present with numbness, tingling, that type of thing in extremities and not know they're diabetic. And obviously in the most extreme cases, they could have an altered LOC, which is there's a couple things it can stand for. For purposes of here, it's level of consciousness. So they could even be in frank coma. And we'll talk a little bit about HHS versus DKA in future slides. For type 1, all similar stuff, but again, these patients often present much iller, if that's a word, iller versus more ill. Anyway, they're going to be pretty hungry initially, but then they end up becoming anorexic. Weight loss is very, very commonly seen and often rapid weight loss that you can see with these patients. And certainly if they're at the point of being ketoacidotic, the nausea, vomiting, abdominal pain, fruity breath, hypotensive, etc. I've seen definitely a handful of these kind of presentations, and at first you think they have just the worst GI bug. They just look like they feel terrible. So certainly something to keep in mind, especially with your pediatric patients there. This is just a picture kind of comparing, type 1 versus type 2 and what you see more of in each. So more polyuria and polydipsia in type 1 versus 2, more weakness or fatigue. Again, they usually feel worse. Weight loss. Usually don't see weight loss with new type 2s. The blurred vision, you can read the list, but I think it's important to kind of know there are some subtle differences there and certainly some commonalities. In childhood, the most common presentation is that classic new onset. So they're hyperglycemic, but they're not acidotic. You could also see them present in DKA, so they're actually acidotic at that point, and then they're pretty ill. And then you could see a silent incidental discovery. I've had a couple of those. Just let's say a sports physical has come in with a kid. I get a urine and they have like 500 glucose, and that kind of initiates the workup. It's really honestly lucky timing at that point where you can find them so early. Before they become symptomatic, because it usually unfolds pretty quickly. Just a reminder of some essential physical exam components in all of your diabetics. And I'm not saying you have to do a full, complete, physical exam from head to toe on each of them every time, but at least once or twice a year when you see them, you really should be doing the full, kind of body exam. Vital signs certainly are important. Skin changes, doing a fundoscopic exam. I know we're not ophthalmologists or optometrists, but getting comfortable with being able to do that and picking up on any kind of changes there. Visual acuity is something easy and quick that your nurses can do for you and monitor, but in reality, they should be going to the eye doctor every year. A good cardiac, peripheral vascular exam, abdominal exam, neuro. It's just really, again, important to be thorough with your patients. The skin needs to be exposed and the shoes off. I've certainly educated my nurses and medical assistants that work with me that, if I have a diabetic patient, their shoes must be off in the room, and they need to be in a gown. Shoes off every time. Really, I think it's important to pick up maybe on some of these subtle changes on their feet that can lead to some pretty substantial complications such as amputation if there's something not detected. And it's amazing. Like, when's the last time you really looked at the full bottom of your foot? I don't know. So I think it's important to do that for our patients when they're diabetic. These are some pictures of what acanthosis nigricans in. So this is almost like a thickened, velvety, dark appearance. The skin usually happens in the body folds, and it's typically going to be a marker of metabolic syndrome, diabetes, that type of class. There are some other etiologies of AN, such as some malignancies, but generally, it's going to be, I've had patients say, it looks dirty and I just can't wipe it off. If you see that, and this is a patient who doesn't already have a diagnosis of diabetes or metabolic syndrome, you need to be looking for that to rule it out. If they don't have a metabolic etiology, then you need to think about some other rare causes like malignancies, but that's for another lecture. These are some other skin manifestations we see. These pictures here to the left are called xanthomas. So they're actually lipid deposits that kind of cause these formations on the skin. They're usually, face is very common, like around the eyes, and often in body folds like the AC fossa. This is on the arm, and then on the back of the hands. You can also see intertrigo, so this is a fungal infection, classic because it's pretty bright red, it's usually very itchy, and you have what's called these satellite lesions, these little red dots kind of on the periphery of the main rash, and you can often see this under the breasts, under the armpits, in between the thighs, vaginal, kind of pubic area, if you will. Eventually it can kind of break down the skin too. You can see some fissures and maceration here of that skin of this patient's genitals. Neuro exam, neuro exam, neuro exam. This is so important to really document this. And when we talk about a neurologic exam of a diabetic patient, we're looking at motor function, we're looking at reflexes, and we're looking at sensation, right? So all of these features are really, really important to examine and document, and using some special tools like our monofilament test to look for sensation. This is also something that our nurses and medical assistants in my office are trained to do, that they already have the monofilament test completed and documented by the time that I get in there. You put about 10 pounds of pressure on this little probe to just get it to bend and see if the patient can sense that. You can also use things like a tuning fork to look for vibratory sense. You can do position sense, and that just looks at different sensory fibers to document and really kind of endorse a diagnosis of neuropathy, which we'll talk about. So that's kind of the clinical side of things. We'll talk more details about complications, but I think, when we have that suspicion of a diabetic, we're going to want to get some labs to either, confirm our diagnosis or kind of point us in a different direction. So blood first and foremost is what we think about. Within that, you can do, glucose is the first thing that comes to mind, right? So you could do a random glucose, meaning, that's not timed specifically with when they last ate, or if it's fasting, it's just a random glucose any time of the day. A fasting glucose is specifically usually an 8-hour fast, and then a glucose challenge test, which if any of you women out there who have been pregnant and have had to do the glucose challenge, that is a specifically timed test where you come in fasting, you drink a sugary drink, and have your blood sugar checked both at baseline before you drink and then 2 hours later, and see how your body responds to a set glucose load, usually about 75 grams of glucose or carbs within that challenge. Also, hemoglobin A1C is a really effective test. Just a little background, hemoglobin A1C is a great marker to know what our blood sugars have done over the previous 8 to 12 weeks, because that's a carbohydrate connected to hemoglobin, which the typical life cycle of hemoglobin is about 8 to 12 weeks. So it really gives us a broader picture of what our patient's blood sugar has been doing in the previous couple of months. And it's always my, kind of line, patients will say, well, last night I did have a piece of cake, or, they want to kind of blame their glucose that came through on their CMP being elevated. And I say, well, but your A1C being 9% tells me that it's not just the cake you had last night. So often you can get them to backtrack a little bit in their storytelling. The other test that is really important, and I often do not see this done enough in primary care, is called a C-peptide level. So C-peptide, I have this little picture here, naturally forms in the body, and it's actually cleaved off from the precursors of active insulin. Okay, and really the takeaway from this is the only way we have C-peptide levels is if our body is naturally producing insulin itself. Okay, so you can imagine with a type 1 diabetic who is not producing insulin, it's going to be low, and generally it's going to be absent. Okay, but with type 2s, it's usually going to be high, right? Because we know with type 2s, we have a ton of endogenous insulin there. It's not measuring how effective it is, it's just measuring the amount that we'll see that. This can become extremely important, as you can imagine, and I didn't include this, and I should have added this to the slide, is the insulin level as well. So C-peptide and insulin kind of goes hand in hand, that those are some initial tests that you'll want to measure in your new diabetics to really discern, yep, their insulin level is high, their C-peptide is high, therefore they're a type 2, versus if it's low or absent, it's going to be a type 1 generally. There's also the autoimmune markers in type 1 diabetes. So remember, more than 90% of our type 1s are going to be this autoimmune process. And because of that, you're often going to have one or more of these autoantibodies detected at the time of diagnosis. And you can see, how sensitive and specific each of them are. I will say over time, these levels do decrease with duration and treatment. But remember, most of our type 1s, we're catching them pretty early in the disease process because they're so symptomatic from that insulin deficiency. So this is very important as well. So really that criteria for how to diagnose it is, looking at fasting, 2-hour glucose challenge, or an A1C, and really knowing those cutoffs. So as you can see, this is important to really kind of cement in your memory going into practice. I mean, certainly when you get labs back, you're going to have a breakdown of thresholds. But anyone that is normal falls into these categories. Impaired is really our pre-diabetics, the impaired glucose tolerance. And then frank diabetes is anyone reaching a fasting plasma glucose of 126 or higher, 2-hour glucose challenge of 200 or higher, or an A1C of 6.5% or higher. These are ADA guidelines. So American Diabetes Association is the primary kind of body of experts that we'll reference. Also the American Clinical Endocrinologist, or the ACE body of experts, is another reference that you'll commonly hear of. Here's the clue. You can't just have one of these numbers abnormal one day and make that diagnosis. A lot of things in medicine need confirmatory backup. So you have to repeat the same test on a different day, or have 2 different abnormal tests on the same day. Okay. You could also make the diagnosis if a patient has classic symptoms of hyperglycemia. So let's say they're polyuria, they have polydipsia, they have fungal infections, and they have a random plasma glucose of 200 or higher. So this is just an example. I might have one patient in front of me that, let's say they come in, they're like, I have these recurrent yeast infections. I'm like, let's just do a finger stick on you. And they're fasting, and their fasting blood sugar is 150. That's higher than the threshold of normal, should be less than 100, right? So they're 150. And guess what? Their A1C, I can do that at point of care in the office, and it's 7%, which is also beyond that 6.5% threshold. So I can feel confident in my diagnosis that day. If you're in a situation that you don't have access to both of these types of tests within your facility, then you could have them do, fasting blood sugar one day, come back the next day, and if it's still elevated fasting, then you have your diagnosis. I would recommend, again, this is a link here to the up-to-date pathway. It really talks about making that diagnosis and what the pathway looks like when you have a patient sitting in front of you. So definitely go through that. This you don't need to commit to memory, but I think it's a great resource when you have a patient who is at an A1C of 11%, but they claim their blood sugars at home are always, less than 150. Well, that certainly can't be true. Maybe they're not checking it enough. Other labs to think about, and again, I'm sorry I omitted insulin from that first slide, but definitely plug that in there on your slide for me. But other labs to think about, urinalysis, urine microalbumin, we're looking for protein in the urine, sometimes ketones, what's that, glucose load. CBC, CMP are obviously important for obvious reasons. One caveat about a CBC, hemoglobin A1C is only effective if you have normal hemoglobin, okay? So think about particularly a patient maybe who has sickle cell. Hemoglobin A1C would not be a reliable test in that patient because it is dependent on the carbohydrate or the glucose linked to the hemoglobin. So it's important to know if there's any, hematologic abnormalities in your patient. CMP, lots of information there, as you know. First and foremost, really their renal function, looking at electrolytes, and that can help kind of give you a baseline for what medications to start and certainly to monitor them over time as well. Lipid panel is certainly important. I also linked the ASCVD calculator. Diabetics just in general are going to be on at least moderate intensity statins, and the ASCVD calculator is a really good guide to kind of help you with that. Testosterone is important to check in men. There's a lot of data and research out there to show that low T levels can cause difficulty controlling some of these chronic diseases like diabetes. And then serum fructosamine. This is a unique test that gives us a little bit of a shorter timeline to think of it like an A1C, but a shorter timeline of looking at blood sugar averages. So this is usually more of a 4 to 6 week average versus 8 to 12, and it specifically links up to proteins to really give us a measurement. So if you did have a patient with sickle cell or some other hemoglobinopathy, you might think about using serum fructosamine on a kind of comparison to the A1C or in place of that. Just a little reminder about other medications that your patients might be on that could cause diabetes or at least elevated blood sugars. These are not unusual medicines that we use. I mean, think about steroids. We use those all the time. Oral contraceptives, thiazide diuretics like hydrochlorothiazide, atypical antipsychotics. The list goes on and on. But just remember to keep these in mind when you're looking at your patient as a whole. Switching gears a bit to complications, we know this drives why we want to be so intensive about treating our patients. This is just a review from earlier about the microvascular versus macrovascular complications, and many patients have both, in fact. Myocardial infarction is going to be the leading cause of death in our type 2 diabetics, as I mentioned earlier. Significant cause of mortality there. And that's, these are patients who have a lot of metabolic problems going on, and the combination of all of these conditions significantly increase their risk of the cardiovascular disease that they experience. PVD, we can see that independently, but often if you have a patient with PVD, they have often a constellation of other vascular risk factors and disease states. We do see that in diabetics, the atherosclerosis is markedly accelerated and just really more widespread. And this can result in ischemia and ultimately gangrene even. And gangrene is actually 30 times more likely in our diabetics. Okay, so bad stuff, certainly something to keep on the radar and hopefully treat early, right? So we've all probably heard of diabetic retinopathy. That is the most common ocular complication we see in our diabetics. I put this little graphic up here to talk about, how common it is. And you can see for a type 1 after 30 years, it's about 100% of the patients have some degree of retinopathy, versus our type 2s after about 16 years have about 60%. So we definitely see a heavier majority with retinopathy in our type 1s. And the two breakdowns of that are the non-proliferative and the proliferative retinopathy. I will talk just a bit about that coming up. Other complications of the eye include macular edema. That usually really affects the acuity and the sharpness of their vision. Cataracts are increased with diabetics, and also glaucoma as well. So you can see why it's important for our diabetics to be in regular care and contact with our eye specialist for routine and regular exams and monitoring. So a little bit more about non-proliferative versus proliferative diabetic retinopathy. The non-proliferative is really the minor side of it and early changes that we see. We can see the microaneurysms, hemorrhages, exudates, edema, and often these patients are asymptomatic with that. However, when it gets to proliferative, these patients will become symptomatic. In fact, it's the leading cause of blindness in the U.S. And ultimately, what happens is, new vessels are forming from the disease because, pathways are blocked, much like when someone has, CAD, neogenesis, they can produce new pathways for blood flow. Same thing can happen on the retina, and those tend to be very fragile capillaries, which can lead to hemorrhaging. And then we can have fibrous tissue that grows, and that can cause retinal detachments as well. So both of those can be pretty catastrophic and ultimately lead to permanent visual loss as well. So again, staying on in front of things, on top of it with our eye specialist are really important. Another key fact is this last point. Up to 20% of our type 2 diabetics have proliferative retinopathy at the time of their diagnosis. That's significant, and again points back to that last slide on my first presentation. If we can identify these people earlier, we're going to get them in the hands of all the specialists they need to see much earlier as well. How do we manage it? Really, they need to be seen by the eye doctor. The reason we give the type 1s 3 to 5 years to really get in for routine management is because we capture all of them very early in their disease state. So it takes a little bit of time. By the time most type 2s come in, they've already probably been diabetic for a little bit of time, a few years at least, sometimes more than that. So really at the time of diagnosis for type 2s, and then annually for both thereafter. They should avoid tobacco. You need to be managing their hypertension because poorly controlled blood pressure can exacerbate or accelerate the retinopathy. There are photocoagulation or laser treatments that can happen, and here are a couple pictures of what that might look like. So all these little dots down here are a laser treatment to either slow those new vessel growths, to cauterize hemorrhaging. You can also do intravitreal injections of the anti-VEGF agents, which just kind of slow down that vascular reproduction. Kind of beyond our scope, but just wanted to mention it for people that say they get injections in their eyes for the retinopathy. That is what they're doing there. Nephropathy, now more commonly called diabetic kidney disease. We do see this more commonly in type 1s, but certainly over time with type 2s we see it as well. And the longer really they've had diabetes and the poorer their blood sugars are controlled is often the major reasons of seeing this. Also family history of kidney disease and hypertension. Really, to make this diagnosis, it's important in the office setting, the best test we can do is a urine microalbumin test. It's a spot test, just like we would have them pee in a cup for a urinalysis. We use a different test stick and it measures how much microalbumin is there, which detects protein much earlier than just doing a normal UA to look for like gross protein, if you will. You need to have at least 2 out of 3 tests abnormal over 3 to 6 month period. So again, a one-timer abnormality is not diagnosis, but 2 out of 3 tests must be abnormal. If you have 2 out of 2, that'll count too. You can also do this timed urine protein test. So that's the 24-hour urine protein or longer, where patients essentially go to the lab, they get a couple big kind of jugs, and that's the only place they urinate over the next 24 hours or given said period. Then they take that back to the lab, and the total amount of protein is measured there. Obviously, that's a more cumbersome test, and it's nice to have the urine microalbumin test to do in the office. Serum creatinine and GFR is not diagnostic, as the protein is. However, it is important to measure, their ongoing creatinine. If it's going up and the GFR is going down, that also can be signs of the diabetic kidney disease. These people need to see nephrology, I would say, at the point of diagnosis, just to get staging done and really talk about, kind of managing their kidneys and their kidney health. Often they're referred to diabetic educator, dietitian, to talk about a low protein diet. ACE inhibitors and ARBs have been protective of our kidneys. Ultimately, dialysis and kidney transplant can be options for our patients as well. Moving on to the most common complication of diabetes, which is neuropathy. Okay, and about 50% of our patients are going to have this. Some at the point of diagnosis, some never get it, and quite honestly, it doesn't often correlate the severity of it to how poor their diabetes is controlled. So it's kind of a anyone's guess, if you will. But needless to say, the reason it happens is because we have these diseased blood vessels from being diabetic. And because of that, it cannot provide appropriate nutrients to our nerves. And you can see here that our nerves eventually shrivel up when the blood vessels disappear and they're not active anymore. So that's ultimately what causes it. There are a couple major categories, the first one being peripheral neuropathy. Even within this, there are several classifications, but the most common that we're going to see is this stocking glove pattern of sensory involvement, meaning like usually it's distally and travels more proximally, so feet kind of traveling up the legs. Most commonly, we see numbness, paresthesias, and pain. The pain can be creepy crawly, it can be burning, it can be hot poker, all different varieties there. But ultimately, if the nerves are not working appropriately, it can lead to callus and ulceration formation because of these high pressure areas that we have often in our feet. You think about normally a person with normal sensation, if we have a shoe that rubs our foot wrong, we're like, gosh, I'm either going to fix that or not wear that shoe again. Diabetics often don't sense that. And so that continual trauma can lead to things like calluses and ulcerations and ultimately amputations if it's not addressed. Diagnosis, we want to do a monofilament test. I showed that a little bit earlier. A full neuro exam. Often an EMG and a nerve conduction study can be done. There are some podiatrists that do little spot biopsies to kind of look at the nerve health. Consider rule-out labs like TSH, B12 folate if someone has paresthesias. I think that's important. Even CBC and thyroid, if someone's anemic or has hypothyroid. And then imaging, ultimately, if they have maybe a nerve compression where you might be thinking about a radiculopathy from the spine, but that's usually going to be unilateral symptoms, not bilateral. And typically neuropathy is always going to be a bilateral presentation when it comes to the peripheral neuropathy. Management of peripheral neuropathy can include, usually first line are going to be your tricyclic antidepressants like amitriptyline, maybe SNRIs like duloxetine or Cymbalta. The anti-epileptics are pretty effective, specifically gabapentin or Lyrica, which is pregabalin. There are some fantastic topicals, although it's a little bit more onerous to the patient to apply those, like lidocaine and capsaicin. There can be electrical nerve stimulation, acupuncture, and foot care is the ultimate importance here. So just a couple more pictures. You can see that this is a distally to proximally spread type of neuropathy, and doing that monofilament test on a regular is important to document. Autonomic neuropathy is the other big category. This is one of those situations where patients often present with this kind of constellation of weird symptoms that you can't put your finger on. I actually have a patient with this, currently. She's been diabetic for years. Her blood sugar is super well controlled and she's compliant. But she's had a lot of issues with orthostatic hypotension, resting tachycardia. Specifically, she's had a lot of cardiovascular stuff. She's been worked up for several other reasons, stress test, Holter monitor, tilt table, all of that have come back normal. And that's the difficulty of this autonomic neuropathy. Remember, the autonomic neuropathy or the autonomic nervous system, that's kind of our, functioning that goes on without our, we don't have to think about it. Our heart rate, our breathing pattern, our constriction of our eyes, our bladder control, our bowel movement, things like that, that should be kind of housekeeping and moving along kind of as programmed. Those things become wacky because of poor glucose control over time. And I listed, a lot of these things, different major organ systems that can see some abnormalities here. And you think about, gosh, that's related. Then in diabetics, we talk about silent MIs. This is why they have that autonomic neuropathy and they don't get the typical symptoms of angina or things like that. With GI gastroparesis, where they just really have slow movement of the gut and things just sit there and they're not, they don't have the normal peristalsis. Erectile dysfunction, which a lot of our male patients have with diabetes, it's because of that autonomic neuropathy. There's not really a fix in general to autonomic neuropathy. We address the individual conditions, certainly rule out more worrisome things or things that we can actually fix, but we usually just treat the individual conditions appropriately. This is just another slide to show all different kinds of neuropathies. I thought this from Up to Date was pretty helpful when talking about, what type of testing might you do if someone has some neuropathy. So talking about some ankle reflexes, vibration, monofilament, things like that, just as a reminder of, including these features within your diabetic neurologic exams. And again, just looking, have them taking that shoe and sock off and actually observing the bottom of their foot. Here are some examples, the top two pictures of, calluses ultimately resulting in ulcerations. And unfortunately, this patient to the right has had every amputated toe and even into the tarsal bones except for the great toe from his diabetes. The bottom picture, this is an example of Charcot arthropathy, so it's CHARCOT, where there's really this destruction of the bony alignment within the foot, and it almost forms this rocker bottom foot, and it just loses all biomechanics. You can imagine because of that, shoes don't fit normally, it can have abnormal wear, and the x-rays are pretty profound. You can see this transformation of normal foot x-ray, and over time you just see complete loss of joint spaces and really just obliteration of the bony alignment. And this is all because of neuropathy. Okay, so this is a major complication. Not super common, but it is one of the extremes that you could see. Just talking about some other kind of general complications. Of course, low blood sugar can be a complication, right, of treating diabetes. By definition, hypoglycemia is if they're below 70 or below. And in diabetics specifically, maybe they've over medicated. Let's say they're on insulin and they gave themselves too much. Maybe they've fasted and don't have enough nutrients to keep their blood sugars up. Maybe they've exercised without those supplemental calories. And maybe they've had some recent medication adjustments as well. As far as medications, the most common that we see causing this would be insulin and sulfonylureas. Okay, so keep that in mind, especially if you have someone super prone to hypoglycemia. I would definitely try and avoid the sulfonylureas. Usually they start getting signs and symptoms about 54 blood sugar and below. Okay, and if you've had it, you know exactly what this feels like: sweating, feeling tremulous, often this intense hunger, sweats. But once it gets about 50 or below, this is where you can see patients present almost like in a stroke-like state. And if any of you have witnessed this, that is one of the things you think about. But they can be irritable, they can be confused, they can actually be comatose, blurred vision, maybe difficulty speaking and getting words out, that type of thing, which can sometimes think about that. So a lot of our EMT friends and paramedics are trained when they go on site that checking their finger stick blood sugar is often one of the first things they can do. And the good news is it can be quickly reversed with giving them, 15 grams of carbs or having a glucagon emergency kit, which is an injectable glucose that often family members are educated to give the patient if this is a common theme. So just to keep that in mind, especially when you're monitoring medications and adjusting things. Here's some examples of 15 grams of carbs. DKA is a major complication. We're not going to spend a ton of time on this or the next HHS, But it is important to know because you need to at least identify this if this walks in your office. Like I said, this has happened to me a handful of times over my 20 years of practicing in primary care, where you can see this actually walk in the door. You're more commonly going to see DKA in your type 1 patients, but sometimes this can be their presenting sign or symptom without a known history of diabetes. Okay, it is a life-threatening emergency. And you can see the mortality increases as you become older. And it can happen in type 2, but like I said, it's much more common in type 1. And usually these folks have some kind of precipitating event like an infection. That's the most common presentation that you'll see. Sometimes folks can go without their insulin, whether it's a socioeconomic issue that they can't afford their medicine, things like that. But nonetheless, there's usually an inciting event of some sort. These patients have hyperglycemia, they have ketosis, and they have an anion gap metabolic acidosis. They are sick. They often have that nausea, vomiting, weight loss, Kussmaul breathing. Click on this link and watch that. This is a pediatric patient in the emergency department who presents with TKA. Fruity breath smell, that's them exhaling the ketones. And then they're often obtunded, very sleepy, sometimes in a frank coma. This is the management. Again, a very, 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 very busy slide. So take some time with it again if you're not in the inpatient side of things, which I don't think you are in primary care. But I think it's important to know IV fluids are the first and foremost treatment, most important treatment for DKA. Okay, so please keep that in mind. Insulin is honestly second to that. These patients come in significantly dehydrated, often 4 to 5 liters dehydrated of fluid. Okay, and then HHS is common. There are some similarities. It is a serious complication of type 2. Diabetics, their glucose levels are usually much, much higher. Look at this chart from Up to Date comparing plasma glucose usually greater than 600 as compared to DKA greater than 250. But they don't have ketosis going on because they're not in an insulin deficient state. Okay, and so you can see the presence of ketones is little to none. And they're usually not acidotic because they don't have these ketone bodies forming from the breakdown of muscle fatty acids that we see with DKA. But their dehydration is often more profound, sometimes 7 to 8 liters. Okay, so again, pivotal of both DKA and HHS is this IV fluid management, and it does have a higher mortality rate than DKA. So it's pretty serious and something to keep in mind if you have a really sick patient walking into your practice.